Hello, I'm Suzanne Northcutt, anesthesiologist. We are here to learn about fatigue, its effects, and how we can mitigate them. There are many definitions of fatigue. Locke and colleagues define fatigue as a physiological state of reduced mental or physical capability, which may develop as a result of sleep deprivation or extended wakefulness, disrupted circadian rhythm, or increased workload. The case of Libby Zion changed medicine. Here is her story as taken from various descriptions. Libby was an 18-year-of-age college student who presented to the emergency room at a New York hospital at 11:30 p.m. in March of 1984, complaining of a 103-degree fever. She was seen by both an intern and a first-year resident separately. Libby's medical history included being placed on the antidepressant medication phenelzine in January, then later additional medications for a tooth extraction, and finally more medications for ear pain a few days before she came to the hospital. There were also other medications which were not in the chart. Libby stated that she used marijuana but no other recreational drugs. White blood cell count was 18,000. Chest x-ray was normal. There was some petechia on an extremity. Libby also presented unusual movements which the junior resident interpreted as voluntary. The residents consulted the referring physician by phone and admitted Libby to the hospital with the diagnosis of viral syndrome and hysterical symptoms. Labs were performed. 25 milligrams of meperidine was ordered for treatment of shivering and agitation. At around 4 a.m., Libby began thrashing in bed, so restraints and 1 milligram of haloperidol were ordered by phone. The intern did not come to the bedside because she was busy with other patients. Libby quieted down around 6 a.m. and was able to take oral acetaminophen. Later, Libby started thrashing again. Her axillary temperature had increased to 107.6 degrees Fahrenheit. By 6:30 a.m., Libby went into respiratory arrest and died. In the medical examiner's report, the cause of death was listed as bilateral bronchopneumonia. Furthermore, sun high fever and collapse followed administration of meperidine and haloperidol while Libby was in restraints. Although cocaine was found in Libby's nostrils and in premortem serum samples, not all labs confirmed its presence, so the medical examiner determined that the evidence of Libby's cocaine use was inconclusive. Libby's case is a blueprint on how to bring reform. Her father, Sidney Zion, was a writer for the New York Daily News as well as an attorney. Mr. Zion felt that his daughter was a victim of hospital understaffing and fought to keep his daughter's case in the public eye. Two issues that were important to him were, number one, the possibility of the interaction of phenelzine and meperidine causing serotonin syndrome. Two, the use of restraints and medication for an agitated patient. The events that followed certainly influenced one another, but the Zion family attorney would describe them in the political pathways as pictured. I will describe them in chronological order. First, the New York Health Department fined the hospital $13 million for substandard care of Libby. In 1986, Libby's case went before a grand jury. The grand jury declined to press criminal charges against the residents, but they did make the following recommendations. Number one, the emergency room should be staffed by physicians that have completed 3 years of postgraduate training and who are trained in emergency care. Number two, junior residents should be supervised by attending physicians in person. Number three, there should be a limit on the working hours of residents, as the house staff in Libby's case had been working for 18 hours prior to seeing her. Number four, rules for restraints should be created. And number five, a computerized system should be used to detect drug interactions. As a result of these recommendations, the New York State Health Commissioner formed the Bell Commission to review the training and supervision of the residents. Based on the Commission's report, the New York State Health Code 405.5 was enacted in 1989, which stated that the residents' work week would be limited to 80 hours, their shifts would be no more than 24 consecutive hours, and the supervising physicians would have to be physically present in the hospital around the clock. In 1994, the Zion family sued the hospital, and the trial was broadcast on court TV. The jury found that both the physicians and the patient shared the blame for her death, as Libby did not inform the staff of her cocaine use. The jury fined the hospital $750,000 for not adequately supervising the residents. Mr. Zion's comprehensive and dramatic media campaign led to the 1999 Institute of Medicine report To Err is Human, which addressed many issues of the healthcare system. In 2001, a consumer advocacy group, along with others, petitioned the Occupational Safety and Health Administration to implement new rules for residents. Also in 2001, the United States Congress introduced the Patient Physician Safety and Protection Act. On July 1, 2003, the American Committee for Graduate Medical Education initiated the new work hour rules for residents. Then in 2011, revised these to further limit hours for interns and second-year residents. Additionally, fatigued residents must be provided safe transportation home or sleeping facilities. There was also discussion in the academic medical community. There were concerns that the abbreviated shifts would result in the loss of continuity of care for the patient and weaken the doctor-physician relationship. For the residents, there would be a loss of learning, since they would not be managing the patients through the changes that occur over an extended time period. The residents' academic time would be limited by the restrictions as well. There could also be a loss of professionalism if the residents saw themselves as hourly workers. In contrast, Drs. Gaba and Howard supported the change in resident work hours. After reviewing multiple studies, they found evidence that the resident fatigue could be linked to depression, anxiety, confusion, anger, and a decrease in psychomotor function. When Drs. Gaba and Howard wrote their opinion piece supporting changing the resident work hour rules in 2002, there were no formal studies directly linking healthcare work fatigue to patient outcomes. Later in 2018, Gates and colleagues presented findings of a systematic review of the literature and found the relationship between physician sleep deprivation and performance, safety, and patient outcomes was not clear. Some of the problems with studying this topic are unvalidated measurements of clinical performance, inconsistent definitions of fatigued and rested study participants, participant surveys with no objective evidence, small size of participant groups, and lack of consideration for circadian effects. Of the varied effects of the suprachiasmatic nucleus, we are concerned with its influence on sleep, alertness, and performance. It causes periods of increased sleep tendency and decreased capacity to function between the hours of 3 and 7 a.m., and to a lesser degree between 1 and 4 p.m. Maximum level of alertness is between 9 and 11 a.m. and 9 and 11 p.m. This cyclic pattern is known as the circadian rhythm and lasts just over 24 hours. Miltner and colleagues consider the circadian rhythm a factor in various nuclear reactor incidents, regardless of whether the personnel were fatigued or not. In 1979, a valve became stuck at the 3 Mile Island nuclear generating station at around 4 a.m. The problem was not recognized until 6 a.m. Human error is considered a chief factor in the partial meltdown that resulted. In 1985, the Davis-Besse reactor in Ohio went into automatic shutdown at 1:35 a.m., losing the main feed water. Then the operator on duty pushed the wrong buttons, stopping an auxiliary safety backup. This was a dangerous scenario, but the reactor was stabilized. In 1985, the Rancho Seco nuclear reactor in California lost power to the control system at 4:14 a.m. Human error was one of the factors that delayed the resolution of the problem. In 1986, the explosion of the reactor at Chernobyl, Ukraine, began with a human error at 1:23 a.m. Avidan explains that the tendency to sleep, called the sleep load, builds as the duration of wakefulness lengthens. Jewett showed that cognitive throughput, a measurement of processing speed, decreases steadily over 48 hours of wakefulness. Cognitive psychomotor performance declined steadily after 10 hours of continued wakefulness and up to 26 hours, by an amount equal to that with a blood alcohol level of 0.004% per hour, reaching intoxication at 17 hours. An international group of researchers in fields relating to fatigue and safety determined that fatigue is the greatest identifiable and preventable factor in causing 15 to 20% of all accidents and transport operations, which they define as commercial operations on the road, in the air, at sea, and on railways. This percentage is greater than that caused by drugs or alcohol. Fatigue has been cited as one of the factors in the Exxon Valdez oil spill in 1989. The National Transportation Safety Board investigative report included as causative factors that the third mate could not maneuver the ship correctly due to fatigue and overwork, and that the company failed to provide a rested and sufficient crew. According to estimates, the 11 million gallons of oil that were dumped off the coast of Alaska resulted in the death of 250,000 seabirds, 3,000 otters, 300 seals, 250 bald eagles, and 22 killer whales, as well as fish. The spill may have been a factor in the collapse of the local fishing industry in the 1990s. The Presidential Commission on the Space Shuttle Challenger accident named sleep loss and shift work as contributing factors to the human error and poor judgment that resulted in the explosion. Less well known is the near miss during the attempted launch of the Space Shuttle Columbia on January 6, 1986, 3 weeks before the Challenger disaster. A system error resulted in a fatigued operator draining 18,000 pounds of liquid oxygen from the external tank of the Space Shuttle Columbia, 5 minutes before it was set to launch. Fortunately, as a result of the lost liquid oxygen, a temperature warning went off in an engine inlet, alerting personnel to a problem. Takeoff was canceled at T-minus 31 seconds. Howard and colleagues studied anesthesia residents in a 4-hour simulated case with both planned and random events. The sleep-deprived group showed decreases in vigilance and memory. A third of them fell asleep. There were no differences in clinical skills or errors. Ladrigan and colleagues studied 2 groups of ICU residents, one group limited to 16-hour shifts and the other group doing extended shifts. Interns in doing the traditional shifts made 36% more serious medical errors, 21% more medication errors, 5.6 times the number of serious diagnostic errors than those restricted to 16 hours of duty. There was no difference in procedural errors. Sleep debt is cumulative, based on the fact that young adults would naturally sleep 8.5 hours per night. 2 hours loss of sleep per night for 2 weeks equals a 24-hour sleep deficit for psychomotor performance. 4 hours of sleep loss per night for 1 week equals the effects of a 48-hour sleep deficit. Resident surveys show that those working extended shifts had a greater tendency for interpersonal conflict, increased alcohol use, and unethical behavior. The effects of fatigue on cognitive performance include impaired learning, focus, vigilance, impaired decision-making, memory deficits, prolonged reaction time, impaired communications, distraction during complex tasks, loss of awareness in critical situations. A trainee is most susceptible to the effects of acute sleep loss on long tasks requiring vigilance. Malice and colleagues define sleep inertia as a state of impaired mental or physical performance capability due to sleep loss or extended wakefulness, circadian phase, or workload that results in reduced capacity to safely perform duties. We usually think of sleep inertia as an occupational safety hazard, but Olson and colleagues consider it a third process in the circadian rhythm sleep debt equation. After all, if there were only 2 processes governing sleep time, people would wake up when recovery from their sleep debt had been completed, like turning on a light switch. If you think about it, even computers need to take a few seconds to boot up. These researchers believe that it is a protective mechanism. Sleep inertia is usually described as grogginess. One may have impaired cognitive performance, which is worse than that of 24 hours of continual wakefulness. It may last from 30 minutes to a couple of hours. It may also affect physical abilities. In people with chronic sleep deprivation, these effects may be severe. On May 22, 2010, Air India Express Flight 812 crashed on attempting to land at Mangalore International Airport. This airport has a short runway and therefore requires the captain of the airplane to perform the landing. The airport's radar was out of service that day, but a procedure had been established for that eventuality. The captain made several errors when he took over the controls for landing, which resulted in descending too fast at too steep of an angle. The co-pilot told him 3 times before landing to go around, meaning to circle the airport and start over. The captain ignored the co-pilot and ended up landing on the runway with only 1/3 of the runway left, at a speed greater than allowed. Then, after successfully touching the ground, instead of using all resources to stop the plane, the captain decided to try to take off and go around. The airplane ran off the end of the runway into a couple of structures, then fell into a gorge and caught fire. There were 158 fatalities, most of whom died from burns. The investigation showed that the captain had been sleeping in his chair for 1 hour and 40 minutes, as determined by the noise of his snoring on the cockpit voice recorder. He woke up a few minutes before descent began. Both the captain and the co-pilot were in what is called the window of circadian low. Airlines who have policies for a pilot to rest in the chair limit naps to 45 minutes, and the pilot must be awakened 30 minutes prior to beginning of the descent. Both of these rules are intended to prevent sleep inertia. The investigative report listed sleep inertia as a prime factor in the accident. In March of 2021, a towboat that was pushing 2 tank barges ran into a lock gate in the Gulf Intracoastal Waterway, causing $2.5 million of damage. There were various problems that occurred. The primary speed indicator failed upon entering the lock. Since it was nighttime, it would have been difficult to gauge the boat's speed visually. Then radio communications with the guide on deck prevented the captain from knowing the boat's closing distance until it was too late. Despite these issues, the investigators felt that the most important factor in the collision was that the captain took over the helm less than 30 minutes after waking up from a 4.5-hour nap. The National Transportation Safety Board determined that the captain had experienced sleep inertia, which was also a factor in him mistakenly deciding to take control of the boat 5 minutes before the start of a critical procedure. There are strategies to mitigate the effects of sleep inertia. First, we can modify work procedures to decrease the likelihood of mistakes, a process which is called sleep inertia proofing. One example is that firemen set out their clothes and other things that they will immediately need if awakened for an emergency before they go to sleep. Some people have double-checking procedures with a teammate, like when nurses used to get a coworker to verify the amount of insulin that had been drawn up. Checklists can be helpful. This type of tool is already a part of many OR environments. The Anesthesia Patient Safety Foundation, in association with other groups, created a collection of checklists for health emergencies, such as malignant hyperthermia, anaphylaxis, and thyroid storm. The current recommendation is to designate someone to review the list aloud during an emergency. Another important action is education. Since people are not accurate in judging their own impairment after awakening, they may be incorrect in which maneuvers are helpful. There are 2 countermeasures that have been proven to be helpful. Number 1, caffeine taken just prior to a short nap, if the nap is protected time. Number 2, light administered with special equipment at the time of awakening and afterward, but the ability to do visual tasks decreases with this method. We must not forget about primary sleep disorders. There are 85 separate sleep disorders recognized. The most common are sleep apnea, insomnia, restless leg syndrome, and narcolepsy. In a 2008 study, only a fraction of the people whose doctor told them that they had one of these problems obtained treatment. A significant percentage of these people reported only 6 hours of sleep on workdays. More than half worked over 40 hours per week, and almost a third worked over 60 hours per week. Screening for these disorders is especially important for employees who are at risk for fatigue just from their work alone. Some companies have set up programs for not only screening but also treatment. Some commercial transportation employers with obstructive sleep apnea programs have seen a 30% reduction in accidents. Another study predicted an $11 billion reduction in collision cost and 980 lives saved because of obstructive sleep apnea treatment for their drivers. In September of 2016, New Jersey Transit Train 1614 bypassed its stop at the Hoboken Terminal and crashed into the terminal wall traveling at 21 miles per hour. One person died and 114 people were injured. Property damages were estimated at $6 million. The National Transportation Safety Board determined that the probable cause was the conductor's fatigue due to undiagnosed obstructive sleep apnea. In the United States, 50% of anesthesiologists reported medical error secondary to fatigue. It was also found that there was an increased risk of unintentional dural punctures between 12 a.m. and 8 a.m. In another study, attending surgeons had more complications post-call if the available time for sleep during the call was less than 6 hours. In New Zealand, 86% of anesthesiologists reported medical error due to fatigue. Also, an increased number of syringe swaps between 2 a.m. and 4 a.m. A syringe swap is administering the wrong medication because of inadvertently picking up the wrong syringe. In 2007, JACO published a review of studies on fatigue. One showed that residents with recurrent 24-hour shifts, when compared to a group working 16-hour shifts, made 36% more serious medical errors and 5 times the number of serious diagnostic errors. Another study demonstrated that 5 or more 24-hour shifts per month resulted in 300% more fatigue-associated errors that led to death. Let's look at an anesthesia resident schedule before the establishment of the work hour rules. This summary shows 10 24-hour shifts in September and 9 in October, with little rest between. In the National Study of Sleep-Related Behaviors of Nurse Anesthetists, 10% of certified nurse anesthetists working in the United States were surveyed. 15.7% stated that they had fallen asleep while providing anesthesia. 48.8% stated they had observed a colleague demonstrating sleep-related behaviors, most often after working more than 16 hours continuously or during night shift. Rogers and colleagues reported that nurses working longer than 12.5 hours are more likely to demonstrate decreased vigilance and are 3 times more likely to make a medical error. Scott and colleagues determined that critical care nurses working longer than 12.5 hours were twice as likely to make a medical error. Trinkoff and colleagues found that the likelihood of nurses experiencing a needle stick injury related significantly to the number of needles that they used per day and to their work schedule. Specifically, the number of hours they worked per day, the number of weekends per month, working evening or night shifts, and working 13 hours on at least one of their work days in a week. Pharmacy dispensing errors include wrong medication, wrong strength, wrong quantity, wrong dosage, as well as incorrect label, etc. The first 4 items have been found to be the most frequent dispensing errors in hospital pharmacies. Ubb and colleagues published a global review of studies done on pharmacy dispensing error rates, including both hospital and community pharmacies. There were inconsistencies among the many studies reviewed, but the stated global prevalence for dispensing errors was 1.6%. A small study of 100 community pharmacies in the United States in 1995 showed an error rate of 24%, with a 4% rate of clinically significant errors. Peterson and colleagues studied pharmacists' attitudes toward dispensing errors in Australia. 70.9 of the 189 pharmacists surveyed were aware of dispensing errors within the past 6 months. The number of these errors totaled 498. Most of the pharmacists stated that the rate of errors was increasing due to the high volume of prescriptions to fill, fatigue, overwork, interruptions, and confusing drug names. Over half of the study participants desired a government-enforced limit for a safe dispensing load. That is, a maximum number of prescriptions that a pharmacist could dispense per hour. In 2014, a relatively healthy 76-year-of-age woman was prescribed a new medication for gout called alpurinol. Unfortunately, she was already being treated with an immunosuppressant for colitis, mercaptopurine. Alpurinol decreases the rate of metabolism of mercaptopurine due to the inhibition of xanthine oxidase. The increased levels of mercaptopurine's active metabolites may result in leukopenia, thrombocytopenia, or pancytopenia. The interaction may be mitigated by decreasing the dose of mercaptopurine. When a blister appeared on the patient's foot 6 weeks later, it ended up getting infected. Unable to fight off the infection, the patient became septic and died of respiratory failure. The coroner determined that the drug interaction was the cause of death. Complaints were filed against both the physician who prescribed the medication and the pharmacist who dispensed it. The pharmacist who dispensed the drug should have been warned about this interaction by the pharmacy's required computer software program, which reviews a patient's medication list for possible drug interactions. Evidence was brought forward that pharmacists sometimes ignore or turn off the warnings of this computer program because of alert fatigue. The programs result in an overload of information which may or may not be useful. Different versions of these programs may have different ratings for the same drug interactions. The pharmacist may have difficulty interpreting the warnings as they can be ambiguous. The National Highway Traffic Safety Administration determined that fatigue causes 100,000 crashes, 76,000 injuries, 1,550 fatalities per year. The European Sleep Society published a consensus statement by an international group of experts which stated that 15 to 20% of all accidents in transport operations, that is to say, commercial operations on the road, in the air, at sea, and on railways, are caused by fatigue. This is greater than the number of accidents caused by drugs or alcohol. Barger and colleagues looked at the risk of interns having a motor vehicle accident associated with driving after extended work shifts when compared to driving after a normal shift. Every extended work shift doubled their risk of having a documented accident and increased the risk of near misses by a multiple of 5. Looking at this monthly, the risk of having an accident increased by over 9% with every extended shift completed that month. And limiting it to just the commute home from work, each shift increased the risk by 16%. In 2001, a man was driving a Land Rover hauling a car on a trailer. As he approached a bridge which passed over a train track, he went through a guardrail and down a steep embankment and onto the railway. He was unable to back off the track, so he exited the vehicle and called emergency services. As he did so, a high-speed passenger train hit his vehicle and derailed onto the opposite track. Soon afterward, a coal train coming from the opposite direction crashed into the passenger train. Fortunately, because of the early hour, the passenger train was not full, but 80 people were injured and 10 people died. The driver was sentenced to 5 years in prison and served half of that time. It was not helpful for his defense that telephone records showed that he had been communicating with a woman he had met on an internet dating site for most of the night previous to the accident, and therefore had not slept before beginning his trip. Could a healthcare provider go to jail for a medical error caused by fatigue? Yes. Our society no longer tolerates accidents. The trend to criminalizing accidents began with motor vehicle collisions and is now sometimes being applied to medical errors. In the past, malicious intent was required to place criminal charges. Now criminal law is being applied to acts intended to serve the public good and which are governed by the legislature. So healthcare providers may not only be sued for negligence and accidents, but also prosecuted. Case 1. An anesthesiologist was investigated by the Board of Medical Examiners after an 8-year-old boy died during a mastoidectomy. A review of the evidence showed that the boy's temperature had climbed to 107 degrees Fahrenheit. The level of carbon dioxide was over 4 times the normal amount, and the endotracheal tube was partially obstructed by mucus. The OR staff reported that the anesthesiologist had fallen asleep. He denied this, but previously he had been reported 6 times for falling asleep. Court records do not indicate why the nurse did not try to wake him up. The physician's defense was that the patient had malignant hyperthermia. An alternate theory was that the endotracheal tube was partially obstructed. The judge of the investigation stated that malignant hyperthermia has a 90% survival rate, and if the problem was a blocked endotracheal tube, that could have been corrected. Among other things, it was determined that the physician failed to respond to evidence of an emergency and failed to remain awake, alert, and vigilant. At the criminal trial, the jury convicted the physician of grossly negligent medical care, which carries a maximum sentence of 1 year in prison and a fine of $1,000. The jurors could not agree on the second charge of criminally negligent homicide, so a mistrial was declared for that charge. The LA Times went into detail about the case. It was noted that the patient was completely covered with drapes and had 2 warmers. The temp probe had not been connected to the monitor. The nurse observed that the physician was not responding to changes in the patient's status, but she hesitated to confront him because he was such a difficult person. Case 2. A labor and delivery nurse was investigated after a 16-year-of-age pregnant patient died due to receiving local anesthetic intravenously instead of the ordered antibiotic. The baby survived after emergency cesarean section. A review of the evidence showed that she had taken the epidural bag from the Pyxis before it was ordered, failed to notice the warning label on the bag, and did not scan the barcode. The nurse had 16 years of experience. The barcode scanning system was new, and the nurse had missed the recent orientation on the scanner because she had been on vacation, and she had worked a double shift the day before. 4 months later, she was charged with negligently abusing a patient and causing great bodily harm. The maximum sentence could be 10 years in prison. The charge was pled down to misdemeanor charges. She was placed on probation for 2 years with the restriction that she could not work as a critical care nurse. The nursing board suspended her license for the amount of time that she had been off work, which was 6 months. Then the board restricted the number of hours that she could work. She was required to complete 54 educational hours in 1 year and to give 3 presentations to her colleagues on how to prevent medical errors. Fatigue is associated with a higher risk of gastrointestinal diseases, cardiovascular diseases, diabetes, obesity, pregnancy complications such as pregnancy-induced hypertension, abruptio placenta, preterm labor, and adverse fetal outcomes. In a 2001 study, women who work night shift compared to women who don't have to have a 60% greater risk of breast cancer. Scholars and colleagues found that healthcare providers minimize the effect of fatigue on patient care. Some of their subjects felt that being tired was, and I quote, a personal failure or an inability to do the job. That is what many people believe. As Luchtenberg and colleagues stated, the traditional ethos of medicine values single-minded commitment with obligations to sacrifice personal and family needs for patient welfare and professional demands. In 2016, the American Society of Anesthesiologists released an article in the ASA Monitor, declaring that physicians bear an ethical duty to minimize the risks to which their patients are exposed. The ASA Ethics Committee has stated, because fatigue may jeopardize patient safety and physician well-being, an anesthesiologist who becomes impaired by fatigue should not provide routine clinical care until this impairment is resolved. They go on to explain that another physician should be assigned if the case is elective, and if there is no other physician available, the patient should be allowed to choose whether or not to proceed. The crash of Air France Flight 447 is a lesson in personal responsibility for fatigue mitigation. This night flight from Rio de Janeiro to Paris was manned by a captain and two co-pilots, one of which did not routinely fly. While the captain was on a rest break, the plane entered an area of turbulence and the airspeed indicator failed. At this point, the autopilot was programmed to disengage. According to the analysis of other pilots, the proper procedures of this situation were not followed, and the co-pilots became confused, causing the airplane to ascend and stall. Correcting a stall is a maneuver that all pilots know, but these co-pilots did not perform it. The co-pilots called for the captain, who took 61 seconds to arrive at the cockpit. During the time it took the captain to arrive, the airspeed indicator began functioning again, but the co-pilots remained confused. They were giving the plane opposite commands in that one was directing the plane to ascend, while the other was attempting to make it descend. The captain attempted to help the co-pilots from behind their seats without sitting in the pilot's chair, where he could see the plane's various indicators. Shortly thereafter, the plane crashed into the ocean and everyone on board was killed. 228 people died. For a long time, the crash was attributed to overdependence on the autopilot, not comprehending the different flying modes of aircraft, which are normal law and alternate law, not practicing manual flying at high altitudes where the air is thinner, not reviewing weather conditions, and not establishing which co-pilot is in charge when the captain is out of the cockpit. But in more recent years, the French investigative body has determined that fatigue was also a factor. In spite of the fact that the crew had had more than a day in Rio de Janeiro to rest, they had had little rest when they started the flight. The captain had only had 1 hour of sleep, and reportedly the co-pilots were also sleep-deprived. At the time of the crisis, the captain was taking a nap and was awakened emergently to assist with the crisis, so he could have been experiencing some sleep inertia. Prior to the crisis, the cockpit voice recorder captured the captain admitting that he had not had enough sleep. There are no work hour rules for physicians after they finish training. We report how our time is spent so that the Health Science Center can be reimbursed for our administrative time by the appropriate agencies. Only hours spent on campus are documented. Call from home is not listed. Time spent making presentations at conferences and participating in national committee meetings are not counted. Because the circadian rhythm lasts a little longer than 24 hours, shifts should rotate from earlier to later. The goal is to avoid sleep debt before starting night float. Pre-call naps of 2 to 4 hours are helpful. Naps during night shifts should be between 20 and 60 minutes in duration. For a 24-hour shift, a 15-minute nap every 2 to 3 hours is recommended. Long naps should be avoided because sleep inertia may affect function if the provider is suddenly awakened to participate in patient care. Just like at home, the call room should be kept dark and quiet. Digital screens should be placed into night mode. To maintain alertness, the provider should take micro breaks during long procedures. Stimulants such as caffeine may be used. The onset of the effects of caffeine is 15 to 30 minutes. The preferred dose range is 200 to 600 milligrams. One author recommended 4 milligrams per kilogram at the beginning of the shift. If taken too late during the shift, caffeine may interfere with post-call sleep, since its half-life is 3 to 7 hours. Bright light improves alertness, but it also has adverse health effects. Bright light can shift the biological clock when this is not desired. For example, it has been recommended to wear sunglasses when driving home after night shift to make it easier to go to sleep. The rise in cortisol caused by light may result in insulin resistance, obesity, and metabolic syndrome. Its suppression of melatonin increases the risk of cancer. The provider can prevent these adverse effects by using special filtered glasses that block light with wavelengths shorter than 480 nanometers. Healthcare providers have been shown to be unaware of their level of fatigue. Apps exist that allow people to test their level of fatigue and alertness. These apps usually use some form of the psychomotor vigilance test, also known as PVT. It measures reaction time to a visual stimulus. Some years back, our residents used a similar app to compare their alertness when rested and when post-call. Later, one of the residents was about to drive back to Lubbock from his pediatric rotation in Dallas. He tested himself with the app and decided it was best to take a nap first. There are also health devices which measure sleep and/or your body's recovery from stress during sleep, so that providers can determine if they are getting enough rest. Other items that are available to improve sleep include a sound machine, blackout curtains, a good mattress, and a bed with an adjustable frame.
Hi, my name is Shawn Noor Mohammed, and I'm one of the anesthesia residents here at Texas Tech. We all know that yawning and drooping eyelids may be a sign of sleepiness. However, stronger indicators could be the presence of microsleeps, such as when a person falls asleep for a few seconds. The person may not be aware that this is happening, though you may notice this as someone's head nodding. In addition, they may have some daytime drowsiness or somnolence, a reduction in psychomotor function as evidenced in published studies regarding the hindrance of intubation skills. Cognitive and learning abilities may also be affected, though cognitive function is less affected in attendings compared to other providers. The presence of decreased sleep latency may also be present, and this is defined as the time it takes a person to fall asleep. Every year, we review the signs of fatigue so that we may recognize it in ourselves and in our team members so that we can intervene and prevent an unsafe environment for the patient and for ourselves. When a person is fatigued, they may have difficulty focusing or forget things that need to be done or communicated. Residents have training in handoff procedures where we are taught a format that will help us communicate all the important information about our patient to the person taking over the patient's care. Depending on the complexity of the case, a handoff in the operating room includes a patient's medical history, current stage of procedure being performed, allergies, pertinent home or floor medications, fluid intake, urine output, estimated blood loss, antibiotics given and when redosing is due, vasopressors in use, IV access, pending tasks, planned destination of the patient, and if post-op ventilation is expected. Handoff helps transition patient care safely, even in times of fatigue. Reduced reaction times and not foreseeing possible problems not only endanger our patients but also ourselves, such as if we chose to drive home after we are fatigued. Our department provides alternate transportation for commuting home and back after an exhausting shift, whether it be an Uber or having a coworker take us home. Emotional signs of fatigue include self-isolation and apathy, withdrawal or remaining unusually quiet. The fatigued person may be uncooperative or rude, creating unnecessary problems, and lack motivation in completing tasks, and they may even appear uncaring for patients. A tired individual usually is not interested in exercise or any other healthy activities. Now that we've discussed the physical, mental, and emotional effects of fatigue, let's discuss how to get some proper rest. It's important for all physicians to get 8 hours of sleep. Residency rules require specific duration of time off between in-house duties in order to also provide time for commuting to and from work and for personal hygiene. Maintaining a regular sleep schedule is important, but also having a bedtime routine that mentally prepares you to go to sleep is important. Relaxation techniques can be helpful as well. It's easier to go to sleep at night if daytime naps are kept short. Don't forget the toss and turn rule, where if you have problems going to sleep for 30 minutes, get out of bed and do something that usually makes you drowsy, then go back to bed. Exposure to natural light schedules during outdoor activity can also help reset the body's circadian rhythm. Things to avoid in order to get a good night's sleep is a heavy meal and caffeine within 3 hours of going to bed. A light snack or drink can be helpful before bedtime. Exercising within 3 hours of bedtime can also prevent sleep, so it's best to exercise earlier in the day. Bright light can interfere with sleep, so the room should be dark. Blackout curtains can help during daylight hours. Screen time within 1 hour of laying down can cause problems with going to sleep. If I must answer my phone during sleep, nighttime phone is best. Avoid negative sleep cues such as studying in bed.
Teamwork techniques taught in team steps can assist in fatigue-proofing a team's performance in caring for a patient. Closing the loop is where one person requests an action and the other person repeats the request, such as when a physician orders a medication during a code and then the nurse repeats the order to make sure it was correctly understood. Depending on the situation, the physician should also check back later to verify that the order was completed. A call-out is where critical information is announced to everyone in the room so that everyone is aware of the situation. An example would be an anesthesiologist informing the personnel in the room that the patient is presenting malignant hyperthermia. This information will allow everyone to immediately begin completing their predetermined task. CUS is a tool used when a provider questions a second provider's action by stating that they are concerned, the situation is unsafe, it is a safety issue. This gives the second provider the opportunity to explain or reevaluate the situation. CUS would be useful in a situation where one of the providers is experiencing sleep inertia. After experiencing the COVID pandemic in 2020, some nurse practitioners and infectious disease specialists separately made recommendations for leading healthcare teams during a crisis when risk for fatigue is high. Here are a few of their ideas. Monitor team members for signs and symptoms of fatigue. Create a buddy system for team members to monitor each other for fatigue. Create a procedure for providers to report themselves or a colleague when they believe their level of fatigue could threaten patient safety. Provide on-site support services such as laundry, sleeping quarters, or food. Reduce the frequency of meetings while still checking on employees' needs. Eliminate unnecessary projects and limit emails.
My name is Estella Morris, Clinical Instructor of the Operating Room at University Medical Center. I've never heard of compassion fatigue until recently when a speaker was invited to the workplace and she brought up compassion fatigue during one of her stories. I became interested in the terminology and began to research it. The concept of compassion fatigue as we recognize it began with Dr. Charles Figley. He is a renowned psychologist and was a responder during the Vietnam War. During his service, he began to notice a change in himself after listening to the horror stories of the traumatized soldiers returning from the battlefield. Dr. Figley was observing the pain and suffering of the wounded warriors and experienced what was called a secondary stress syndrome. In 1995, Dr. Figley changed the phrase to compassion fatigue. Although I have many years of nursing experience, I mistakenly thought that compassion fatigue and burnout were the same. However, when I read more about compassion fatigue, I realized the two were separate issues. According to Hinderer and her colleagues, compassion fatigue is a loss of the nurse's ability to nurture patients. The World Health Organization defined a nurse burnout as an occupational phenomenon that occur when ongoing stress on the job isn't adequately managed. Elizabeth Wolter's article describes compassion fatigue as a phenomenon of stress resulting from exposure to a traumatized patient rather than to the trauma itself. What makes compassion fatigue different from burnout is that compassion fatigue is a direct result of being exposed to other people's trauma. Burnout, however, can develop without exposure to trauma. Undeniably, working excessive hours and long shifts can lead to physical and mental fatigue and can even cause sleep deprivation. If you are burnt out, you have decreased energy and ability to focus, a poorer recollection of things, and may struggle to make clear decisions. The burnt-out person's sense of purpose can then be replaced with feelings of frustrations. Both compassionate fatigue and burnout characterize physical and emotional exhaustion, but they are different. In compassion fatigue, repeated exposure to trauma alters the nurse's ability to feel compassion and care for others, not just for their patients, but for people in the nurse's other relationships as well. This is not the case in burnout. Burnout can leave nurse to depersonalizing their patients, but it doesn't cause them to do the same to people they know that aren't their patients. Like burnout, compassion fatigue can impact the delivery of patient care. The nurse's work performance is diminished by making a nurse less understanding of a patient's feelings and opinions. This in turn can lead to poor assessment and treatment plans for improving the patient's health and outcome. Ways to combat compassion fatigue. Some of the recommendations include taking time for self-reflection and trying to recognize what is wearing you down. Talk to someone who is a good listener, a person with whom you feel connected to and will listen to you without judgment. Try to understand the pain you are feeling is normal. Take some time off. Take care of yourself by getting sufficient rest, maintaining a healthy diet, and staying physically active. Build emotional resiliency by seeking support systems, counseling, classes on stress reduction, and help through the organization's Employee Assistance Program. Find and develop interests outside of your job and try to identify what is important of you. This knowledge can help you redirect, refocus, and adopt a better lifestyle.